I'm Dr. John Kruse, and today I'm going to be talking about glutamate and ADHD. So as usual, I'll start with the take-home message, and then I'll launch into the main talk. Take-home message is that glutamate is the most abundant neurotransmitter in the brain, but it's been widely neglected for studies for a whole host of mental health conditions, including ADHD. It's a complicated as well as abundant system, so there's a multitude of receptors, subsets of receptors, and transporters. We do currently have drugs that affect glutamate that are being used in Alzheimer's and depression. None have been FDA approved that are primarily glutamate acting for ADHD. But there is some evidence, and probably the best evidence is from Memantine, that some drugs that primarily work on glutamate can be beneficial for ADHD. So that's the take-home message, and now to launch into the main talk. So what is glutamate? Glutamate is an amino acid, so it's one of the 20 basic building blocks of proteins. It is not an essential amino acid, so the essential amino acids are the ones that your body needs to take in your diet because it can't make them. It can actually make glutamate. And in addition to your body making glutamate, glutamate is actually the most commonly manufactured in worldwide societies today. So glutamate is also responsible for that umami taste that's found in seaweed, cheese, mushrooms, tomatoes. Monosodium glutamate is just sodium salt of glutamate. And glutamate was named after gluten. Gluten is the protein in grains such as wheat and barley in particular that helps bread rise and gives it structural integrity and ability to expand and other wonderful properties that some people are allergic to. As a neurotransmitter, glutamate was late to the table in terms of being discovered, and part of that was in the 50s, 60s. There were discoveries of serotonin, norepinephrine, dopamine, these little systems that start at the base of the brain and spread out all over and sort of are discrete real neurotransmitter systems. In contrast, there is so much glutamate being found in the body and again in the brain. It was already abundant in the body because it is a basic building block of protein. And there was so much of it in the brain that they figured it couldn't possibly be a neurotransmitter until they started studying it more closely and precisely. And it turns out that up to 40-50% of neurons use glutamate as their neurotransmitter. So it is far and away the most abundant neurotransmitter in the brain. That's throughout the animal kingdom, or higher vertebrates anyway. And not only do 40-50% of neurons use it as their major transmitter, about 90% of neurons have at least some glutamate receptors, so at least some input from other glutamate neurons. So rather than viewing it as a sort of discrete set of circuitry like we can with dopamine or serotonin and norepinephrine, everybody's using glutamate to some extent, and that makes it challenging because if you're modifying it, you may be modifying it in places you don't want to. Further complicate the picture, glutamate is the precursor to GABA. So just one enzymatic SNP cleaves glutamate into GABA. It does need the vitamin B6 as a cofactor with the enzyme. GABA is the most abundant inhibitory neurotransmitter in the brain. It's used mostly for very short local networks. Glutamate is also an indirect precursor. First it gets converted to serine amino acid and then to the amino acid glycine, which is probably the second most common inhibitory neurotransmitter in the brain and is particularly abundant in the spinal cord. So lots of glutamate floating around, lots of glutamate affecting other neurotransmitters directly by synthesis of them, and interaction is regulated by them. So adding to the complexity of glutamate, there's 3 big types of glutamate receptors. This is leaving out a few minor types. One of the big classes is the AMPA receptors. These are fast ion channels. So when you're taught how neurotransmitters work in Neuroscience 101, these are ion channels. So when glutamate binds to an AMPA, very quickly it changes how ions flow in and out across the membrane. Sodium flows in, it depolarizes the nerve that's getting a signal, sends the action potential along, and then potassium moves out of the cycle to reset or repolarize the ion balance, making it ready for another potential activation. In contrast, much of the research in mental health, not all, but most of it, and the drugs are focused on NMDA, which are called slow ionophore channels. So in addition to when glutamate binds, this doesn't just open channels for sodium and potassium, it also opens channels for calcium ions. They are particularly concentrated in the prefrontal cortex, where the circuitry for much of our executive functions exists. The NMDA receptors are responsible for a process called long-term potentiation. So not only do they allow relatively quickly ions to flow in and out, they have long-term implications for the brain. So long-term potentiation is the critical process by which memory gets stored, why learning happens, that underlies much of neuroplasticity or change over time with practice, exposure. So NMDA receptors are responsible for fear acquisition, for working memory, a whole bunch of very important brain processes, many of which are affected in a variety of conditions. NMDA receptor is composed of two big subunits, and the glutamate binds to subunit number 2, while glycine, again, that the inhibitory amino acid neurotransmitter, needs to bind to the other subunit for any ions to be flowing. So we probably should be calling it a glutamate glycine receptor, not just a glutamate receptor. There's also a whole subset of glutamine receptors that are metabotropic, which means they're not basically affecting ion flow in and out. They're activating or deactivating, depolarizing the nerve quickly. They are involved in second messenger systems, involved in protein synthesis, gene expression, slow effects, and that also is part of neuroplasticity in the brain. Furthermore, there are a whole set of glutamate transporters for moving glutamate in and out of different intracellular, cellular spaces. Some of these are on neurons, many of these are on glial cells as well. So storage within glial cells is an important regulatory mechanism for glutamate levels. There's glutamate-glutamine cycle. In addition to just point-to-point synaptic release levels, glutamate's so abundant and there's so many glutamate receptors, there has also regional or more global effects where presynaptic release can affect more globally than just a point-to-point action for glutamate. So one of the important roles in a bad way for glutamate is a process called excitotoxicity. And this primarily involves NMDA receptors. But if too much calcium flows into the neurons, it actually kills mitochondria. It releases nitric oxide, which is also causing damage to other oxidative damage, electron transfer damage to other parts of the cells. And it's responsible for killing cells. So in the process of stroke, where hypoxia cut off the blood flow, traumatic brain injury, where there's actually trauma to the brain, usually shearing rather than just concussive forces, in Alzheimer's and in Parkinson's, where there's degeneration of neurons and death. Part of those all involve excitotoxic processes where too much glutamate is released, too much calcium flows into nerves, nerve cells wind up dying. So glutamate's important, essential for the body, but too much of it can be actually toxic. Another area that's particularly important for ADHD is that there are, and this is grossly oversimplifying, somewhat reciprocal interactions between glutamate and dopamine. So in areas where we have low dopamine, we often have high glutamate and vice versa. And re-regulating glutamate can affect dopamine levels. Re-regulating dopamine can affect glutamate levels. So not surprisingly, given how abundant glutamate is, there's conditions associated with low glutamate in certain areas, like schizophrenia. There's conditions like Alzheimer's and depression where glutamate levels seem to be high. In ADHD, there seems to be too high a level of glutamate in frontal cortex, maybe anterior cingulate and striatum. Studies have found low levels of glutamate in different areas. Again, it depends a lot on what area is being looked at, situation or task the brain's engaged in. So glutamate dysregulation seems to be found in ADHD, related more specifically to impulsivity rather than necessarily ADHD. And this is just to sort of highlight, this is oversimplifying. Motoric impulsivity, which is you can't inhibit your impulses, you're too jittery, you're moving too much. And emotional impulsivity are associated with high glutamate and prefrontal cortex, whereas impulsive decision-making and unable to do delayed discounting or wait for more rewards in the future, you want it all now, which is associated with ADHD, is associated, at least in some studies, with hypoglutamate, low glutamate in the prefrontal cortex. Glutamate seems to be involved in ADHD. It would be hard for it not to be. And what do studies with different drugs teach us or not teach us about this? I have a separate talk on ketamine, so you can refer to there. So ketamine is an NMDA blocker. Whether that's how it works for depression, most of the research is focused on that. There's some evidence, maybe opioid receptors are too. Ketamine rapidly reduces prefrontal glutamate. Whether longer exposure leads to, again, low glutamate everywhere, it's probably more complicated than that. And despite numerous ketamine clinics advertising that ADHD is something that can be treated with ketamine and that there's research to back that up, there actually is not any published clinical research on ketamine for ADHD. Evidence from rats, actually in prenatal exposure during pregnancy, suggests that ketamine exposure then can actually lead to an ADHD-like picture. So an NMDA blocker, dextromethorphan, somewhat similar to ketamine. So dextromethorphan, and I have a video on this, is considered to be the active ingredient in Auvelity. That's the fast-acting antidepressant that was approved in the U.S. about 2 years ago now. It's a combination of dextromethorphan and bupropion. The bupropion theoretically is below antidepressant dosages, and it's there primarily or entirely as a 2D6 blocker, which blocks the degradation of dextromethorphan so it can exist longer and have a longer acting effect. So Memantine is an NMDA blocker that's FDA approved for treating Alzheimer's disease. It's been around for 20 years. It's more free of side effects than the first drugs approved for Alzheimer's, which are acetylcholine-acting drugs, which all of them had lots and lots of GI side effects. Memantine, lower rate of side effects, again, working on the NMDA blocking action. And there are at least 6 different, somewhat well-done studies looking at Memantine for ADHD. 2 different meta-analyses have looked at those 6 studies and came to roughly the same conclusions. So to frame it though, these 6 studies used less than a total of 200 patients. There were 3 studies in adults, 3 studies with kids. 4 of them were randomly controlled. 2 of them are open label studies. Most of these were conducted at 2 different laboratories. Some of these studies looked at Memantine alone. Some of them were adding it on to methylphenidate. But the overall take from it is that it appears to be beneficial in a number of studies for ADHD. The effects are roughly on a par with methylphenidate. In general, it was well tolerated. Most of these studies were looking anywhere from 5 to 20 milligrams. 10 or 20 is a common dose and used for Alzheimer's. Some patients did have loss of appetite, other gastrointestinal side effects, and headaches. A few people in these studies have confusion, loss of concentration, so things you certainly would not want to have for anyone, particularly in ADHD. Developed as a offshoot of Amantadine. I have a separate talk on Amantadine. Amantadine is originally an anti-influenza drug. It's used off-label for ADHD and secondary ADHD, and it does have NMDA blocking action. Other NMDA blockers that we have around, one is Acamprosate. That's a drug that's FDA approved to treat alcohol abuse. Acamprosate isn't just a glutamate blocker at the NMDA site, but it also has GABA A action, so that makes it a little more complicated. I haven't found any studies at all looking at Acamprosate and ADHD. One of the other FDA-approved glutamate-acting drugs is D-Cycloserine. It's a partial blocker of the NMDA receptor at the glycine site subunit. And for years, it's been a mainstay of treatment for tuberculosis, so it has antibacterial action. And interesting, and this is important for studies of other glutamate-affecting drugs, there are some studies with D-Cycloserine where in a single dose actually improves cognition in humans, but repeated doses didn't seem to have that effect. And the thought was that after repeated use, there is upregulation of blocked receptors, and that cancels out or negates some of the acute effects. So one of the things to be aware of in any of these studies is glutamate system is really important for the brain, and there can be upregulation and consequences of treatment that may cancel out what we're attempting to do. N-Acetylcysteine affects glutamate levels and glutamate release indirectly. There is some limited evidence N-Acetylcysteine can be effective or helpful in ADHD. Atomoxetine, Strattera, the first non-stimulant approved and primarily considered a norepinephrine blocker, has been shown to have NMDA blocking properties at physiologic levels. Lamotrigine, which is the anti-seizure drug used as a antidepressant mood stabilizer, inhibits the AMPA, so not the NMDA. It's also decreasing glutamate release. Topiramate, also used as a mood stabilizer, also is originally an anti-seizure drug, blocks the AMPA receptor, and the kainate glutamate receptor. I haven't talked about that one. I can't find, as of beginning of 2025, any research on either of those drugs and their potential use in ADHD. Summary: really abundant, really common, really hard to mess with it because it affects so many things. Levels in one area may not be indicative of glutamate levels in another area. At a gross oversimplification, there is some reciprocity with the dopamine system. So in areas when dopamine is high, glutamate tends to be low, and vice versa, and they do regulate each other. Of the drugs working on glutamate systems, the one with the most evidence, meager but encouraging, would be Memantine, the drug that's FDA approved for Alzheimer's, but may well have a benefit for ADHD. Be back with videos next week. Stay healthy, stay happy.